Are you having a hard time understanding atrial fibrillation? Well, guess what? This video is for you. I am the nurse Dr. Asia, and this channel is dedicated to helping you, yes, you, pass nursing school. So don't be stingy. Share this with your classmates so you all can pass your exam. So today's lesson will focus on atrial fibrillation. So let's get started. So first I want to go over a EKG wave to let you know how it's supposed to look and what it actually means. So our P wave shows atrial depolarization. So that means that the atrium contracts, and when the atrium contracts, it then pushes the blood to the ventricles. All right, so then we have our QR complex, and that shows ventricle depolarization. So that's when the ventricles are contracting, and once the ventricles contract, it pushes blood to your lungs and your body. Then you have your ST segment, and this is a pause between contraction and recovery. The heart muscle is starting to recover right here. And then your T wave shows ventricular repolarization, and this is where the ventricles are resetting and getting ready for the next beat. So before we go into abnormalities, we need to know what it should look like and what is the role of each thing, whether it be the P wave, the QRS, or the T wave, or the ST segment. All right, so let's start with just looking at the name atrial fibrillation. So it lets you know that this is going to be a problem with the atrium, right? And also we know that the atrium is equivalent to the P waves. So let's dive into it. So I just wanted to mention that. So just look at the name atrial fibrillation so that we know we're going to be having problems with the atrium. And then we will look for the atrium with the P waves. All right, so what is AFib? So AFib is an irregular, often rapid heart rate caused by chaotic electrical activity in the atria. All right, so the key issue, why is this so dangerous? It's because the atria actually quivers instead of contracting effectively. So instead of, the atrial contracting like it should, it's basically just quivering, right? It's just quivering. It is not contracting like it should. So what happens when when the atria starts to quiver? Blood starts to pool, right? So blood is not being pushed out like it should, but blood actually starts to pool. And whenever blood starts to pool, or whenever blood starts to slow down, that patient is now at risk for blood clots, and blood clots put you at a risk for a stroke. So a lot of times you will see that your nursing professors, they will just say to know atrial fib as the atrium quivering. Is not, and quivering is just like shaking, right? It's not contracting like it should. So we want to think about it. If the atrium is not contracting like it should, then guess what? We're not getting adequate cardiac output that we should get. So let's tie it all together. If your atria is having problems, that can lead to there not being enough blood getting to the ventricles to pump out to the body. So remember, with atrial fibrillation, the problem is with the atria, and the atria's job is to contract and push blood to the ventricles. So how to recognize AFib on an EKG? So the thing about atrial fibrillation is we know that the problem is with the atria. So the atria is going to be our P wave. So we're going to see problems with the P wave. So with atrial fibrillation, there is going to be no identifiable P waves. So as we look at it on the screen, we don't see P waves, right? We kind of just see some little scribbles here, but we don't see an actual P wave. So that lets us know that this patient is in atrial fibrillation. Also, you will see irregular QRS spacing. So you can see how it, let me grab my little lighter. You can see like right here, it went right here, and then it got shorter here, and then it got even shorter. So your QRSs, they are irregular. Also, the biggest thing is, you guys, how you're going to notice that the atrial rate is going to be 300 to 600 beats per minute. And the ventricular rate, that could vary. But you guys, it is important that, remember, if we're talking about atrial, we're talking about the atria. And we're talking about our P waves. So you see how these P waves right here, these are not P waves. These are not P waves, okay? So with atrial fibrillation, what did I say? That was like a quivering. So our quivering is just a shaking, right? So you can see how I'm doing this, that quivering. That's what it looks like on the screen, right? A little scribble scrabble. So remember, with atrial fibrillation, you're not going to be able to identify your P waves. You will see in regular QR spacing, and your atrial rate could be 300 to 600 beats per minute. So remember, that is super fast. So what are some causes of atrial fibrillation? So the mnemonic is PIRATES. So pulmonary, if a patient has pulmonary issues such as COPD or pulmonary embolisms, that can cause strain on the heart, and that could trigger atrial fibrillation. If your patient had a heart attack, any type of ischemia, that could lead to poor blood flow to the heart, which irritates the atria. If your patient had rheumatic heart disease, damaged valves from past infections can disrupt the heart rhythm. If your patient is an alcoholic, if your patient has a sudden heavy drinking, that can cause temporary atrial fibrillation. If your patient has hyperthyroid due to the overactive thyroid, that causes the heart to speed up, and it can trigger arrhythmias. Also, remember your electrolytes such as your potassium and magnesium, those can cause can mess with the heart signals as well. Hypokalemia and hypomagnesemia. Sepsis or surgery, any type of stress or infection can trigger abnormal heart rhythms, okay? So that's just one thing you kind of, if I could tell you a takeaway, that any kind of stress, inflammation, any trauma, that can trigger that patient to going into an abnormal heart rhythm. So what to do if a patient goes into a fib? So this is going to be tested heavily. So you need to know this. So the first thing that you want to do is you want to assess. So you want to check your patient's vital. You want to assess your patient's mental status to see how are they. Are they stable or are they unstable? So what's a stable patient? A stable patient is a patient that is able to talk to you. A stable patient meaning that their vital signs, have stabilized out. Their vital signs are, not super low or, or not super high. Now their heart rate with atrial fibrillation, our heart rate can be really fast with atrial fibrillation, right? But is the patient exhibiting any symptoms from their heart rate being super fast, right? So that's one thing you need to know. So if that patient is stable, then guess what we're going to do? We're going to just slow down the heart rate with medications, and we're going to talk about that in the slides to come. So if the patient is stable, meaning you look on the monitor and you see that their heart rate could be 120, 150, but they're stable, then hey, we're good, right? We don't have to, jump to extremes of how we would if they're unstable. Give me a second. But let's say if this is a new onset for the patient, let's say you see atrial fibrillation on the monitor and you ask your patient like, hey, do you have atrial fibrillation? And they tell you, no, I never heard of that before. You do want to contact the provider because that is something new. But a lot of patients come in with atrial fibrillation and they're actually stable. So what do is we just place them on a cardiac monitor and we just continue to monitor them. And then the physician may put some medications on there that will slow the heart rate down. Now, if your patient is unstable, meaning they're experiencing hypotension, they have chest pain, they now have an altered level of consciousness, meaning they're now not answering you and all those kind of things, we'll prepare for cardioversion. So we'll talk about that more in the slides to come, but we want to make sure that we first assess our patients to see if the patient is stable, if the patient is unstable, because a lot of patients have atrial fibrillation, you guys, and they don't even know. But it's when that patient starts to develop signs and symptoms is when we really need to jump in and do some things. So oxygen, you need to provide oxygen if needed. If your patient's SAT starts to drop or something like that due to the decreased cardiac output, then we need to put the patient on oxygen. Also, if you want to make sure that you have an IV access, because we're going to need to give that patient IV medications. So let's dig into cardioversion. So we're going to do cardioversion if a patient has unstable AFib. So remember, unstable AFib, that's going to be the patient who is experiencing chest pain. That's going to patients that is experiencing hypotension, and a patient who could be experiencing altered level of consciousness. So remember, this patient is not stable. So what is cardioversion? Cardioversion is a procedure used to reset the heart's rhythm back to normal when it's beating irregularly, like with atrial fibrillation. So you have a synchronized cardioversion. So basically, a shock is delivered through the pads on the patient's chest. So you would just put the pads on the patient's chest, and then a shock would be delivered through that. So it is timed with the patient. That's why it's called synchronized. It is timed with the patient's heart rhythm to avoid shocking during the wrong part of the cardiac cycle. So it is used when the patient is unstable, and sometimes it can be done with sedation so the patient can be comfortable. So remember, this is just like you placing just like the patient receiving a shock, with the pads. I'm going to make sure that I post a picture so you can actually see what I'm talking about. But remember, cardioversion, the goal of cardioversion is to shock that patient into it back to a normal rhythm. Now, that is the physician's job to order cardioversion. So it's not going to be you as a nurse, you see AFib on the monitor, and then you're going to be like, oh yes, we're about to cardiovert this patient. No, you need a physician's order to cardiovert that patient, and the physician, they then will tell you the settings and all that kind of stuff to do. All right, so here is the picture of electrical synchronized cardioversion. So as you can see that the patient was in an irregular heart rhythm right here before cardioversion, and they put the pads on them, and then as you can see, it restored the rhythm right there. So for those who are visual learners, here is how it looks. Now, if our patient is stable, we can do a pharmacological cardioversion. And this one is using medications such as amiodarone or flumecanide to restore the heart's normal rhythm. So you try this if a patient is stable. So with the patients who are unstable, they actually get the pads on them, right? That synchronized cardioversion. But if your patient is stable, we can try giving them medications that can actually restore the normal rhythm. And this is for your stable patients, okay? So let's talk about medication management. I have a mnemonic. AFib needs A, B, C, and D's to stay alive. So we have A, which is anticoagulants, and our anticoagulants prevents blood clots, right? It prevents the patient from developing a stroke, right? So we want to make sure that we educate our patients on their anticoagulants, bleeding precautions, and things. Whether they're on warfarin, we want to teach them to monitor their INR, and we want to talk about vitamin K consistency. If they're on Eliquis or Xarelto, we want to teach them also about bleeding precautions. Our next class is going to be our beta blockers. So our metoprolol, our atenolol, what is their job going to be? Their job is going to be to slow the heart rate. So when we slow the heart rate, the heart is able to pump better, okay? So it helps with slowing your ventricular rate so the heart doesn't wear out itself, okay? So next we have our calcium channel blockers. And these medications also slow down the heart rate, but the way they slow down the heart rate is just a little different. So they block calcium from entering to the heart muscles, which causes slow electrical conduction. So this will also help the heart, not work as hard, okay? And the next one is going to be digoxin. So digoxin works by slowing down your electrical signals going to the ventricles. So this is going to be used in patients with heart failure or patients who have low blood pressure who cannot tolerate beta blockers or calcium channel blockers. So remember, when we slow down the rate of our heart rate, it allows our heart to pump better. So what are some patient teachings that you want to teach your patients? So you want to teach them to take their medications as prescribed, and any type of patient teaching that goes with a specific medications, such as, bleeding precautions, and when they are on those blood pressure medicines, that orthostatic hypotension could be a side effect that they can experience. So you want to teach them to sit on the side of the bed and little things like that. So whatever signs and symptoms and stuff, you want to teach them about that, what they can experience. You want to check your pulse daily and report irregular or very fast and slow heart rate. So you want to teach your patient how to check their pulse, whether it be, through a machine or actually teaching them. And then just letting them know, like, hey, if your heart rate gets to this rate right here, which the physician will let them know, then you want to come in. If it is super slow or any type of changes that you're experiencing that you normally don't experience, you want to come in. Lifestyle modifications, so getting that blood pressure decreased, right? Controlling that cholesterol, all that stuff matters, right? Especially when I talked about on the slide where it talked about the causes. You may need to stop drinking, you need to stop drinking alcohol. So you want to talk about basically some risk factors that puts that patient at risk. We then want to do lifestyle modification. If that patient has to lose weight, they need to do those things. No stroke warning signs, and we want to use FAST, that is facial drooping, arm weakness, speech difficulties, and that you need to call 911 if you are experiencing these things. And you want to make sure that they are keeping up with all their follow-up appointments and their lab checks. So we have learned a lot. So now let's put it to practice and do some NCLEX questions. A nurse is caring for a client who has pericarditis and is feeling a new onset of palpitations and shortness of breath. Which of the following assessments should indicate to the nurse that the client may have developed atrial fibrillation? Is it 1, a different blood pressure in the upper limbs? 2, a different apical and radial pulses? 3, the difference between an oral and axillary temperatures? Or 4, the differences in upper and lower lung sounds? So I'm going to give you some time to think about it. If you chose 2, the difference between different apical and radial pulses, then you are correct. So remember, with atrial fibrillation, you have rapid, disorganized electrical activity of the heart in which the atrial contracts too quickly and sends these impulses to the ventricles. So the presence of a pulse deficit between the apical and the radial pulses is an indication of atrial fibrillation. So you want to make sure that you know that this patient can experience a pulse deficit, right? And that's just because of the atria contracting and sending all those signals to the ventricle. A nurse is caring for a client who has atrial fibrillation. Which of the following pulse characteristics should the nurse expect? 1, slow. 2, not palpable. 3, irregular. Or 4, bounding. So I'm going to give you some time to think about it. If you chose 3, irregular, then you are correct. So remember, with your atrial fibrillation, that your patient is going to have what? You're going to have quivering of the atria, but then also with your ventricles, you're going to have irregular ventricular contractions. So with that one, you're going to see the patient have an irregular pulse. A 72-year-old patient is on telemetry. The nurse reviews the rhythm strip above and notes a sudden onset of irregular rhythm with a ventricular rate of 140 beats per minute. The patient is alert but reports lightheadedness and palpitation. Blood pressure is 108/64. Oxygen is 96 on room air. What is the nurse's next action? So we're going to use the strip on the screen. So is it A, call a code and prepare for defibrillation? B, administer IV cardizem as prescribed? C, prepare for synchronized cardioversion? Or D, encourage the patient to bear down? So if you chose B, administer IV cardizem, then you are correct. So this medication is what? A calcium channel blocker. So remember, this patient is stable. The patient blood pressure is stable. It says that the patient is alert So we're going to just give this patient medication in order to bring down their heart rate. So I hope you guys got this one correct. And just like that, the lesson is over with. So I hope that you have learned a lot from this video. So share it with your classmates, and I will see you guys in the next lesson. Thanks for watching.